Okay, good morning, everyone. I'm Dr. Wang from Zhonghua Christian Hospital from Taiwan, and I'm from obstetrics and gynecology department. And now I'm currently chief of our high-risk department, high-risk pregnancy department. And today I'm going to talk about the preeclampsia. Okay, today we are going to learn about the hypertension disease in pregnancy, the incidence and importance of this disease, and the pathophysiology of preeclampsia and the risk factors, and how do we measure the proteinuria, and when the preeclampsia happens, how do we do a management? And also, the preeclampsia can also occur postpartumly, so postpartum preeclampsia. And of course, the most important thing now is to do a screening and the population. So, because of the preeclampsia is a very complicated disease, and so if any one of you is interested and want to look for more information, these are all the guidelines we look up to. So today we will reference from all these guidelines, like ACOG from 2020 and the Canada guideline, New Zealand guideline, and England guideline, and also ISSHP from American, and also the FIGO guidelines. All these guidelines are talking about preeclampsia, but we will find out that in each different guidelines, they have different criteria, different standards, and they have some difference, but most of them are very similar. Similar, they are similar and the same in the same ways. So let's look at this disease. Okay, so now we have to understand what is a hypertensive disease in pregnancy. If a patient, a woman, come to your clinic and we found out she had hypertension before gestational weeks, before 20 weeks of gestation, then we'll call it as a chronic hypertension. So if it's early, like only 12 weeks of gestation, you finally already have a hypertension, then it is already a high risk group. And for gestational hypertension, we define it as a new onset hypertension after 20 weeks of gestation. So this is a very important definition that all this disease that happens after 20 weeks of gestation. If any of the patient they have a proteinuria or they have seizure before 20 weeks of gestation, then it's not pregnancy related. It might be a chronic disease like she already have an eclamptic disease before, or she already have a proteinuria, she have a like a nephrotic syndrome before. It's not pregnancy related. But if it's a new onset hypertension, then we call it gestational hypertension. And if after 20 weeks you have hypertension and you have proteinuria, then we already call you as a preeclampsia. But if you don't have a proteinuria, but you have a hypertension with end organ dysfunction, then we can call you also as a preeclampsia. But what if a patient have a chronic hypertension and she developed proteinuria or end organ dysfunction? Then we call it as chronic hypertension with superimposed preeclampsia. And more severely, if the patient develops a hemolysis, a thrombocytopenia, and elevated liver enzyme, then we call it a HELP syndrome. I think maybe many of you understand that this disease is very severe. And of course, if you have a preeclampsia or chronic hypertension with superimposed preeclampsia, or you have HELP syndrome and you develop seizure attack, then we call it eclampsia. So all this disease and we're talking about today is that we want to control the eclampsia. And this is a very important disease. It's happening more and more in the whole world. Like in worldwide, it's 4.6% to 10% of pregnancy. So like if 100 women got pregnancy, now almost 10 of them will get preeclampsia. And before 34 weeks is about 0.3%, but after 34 weeks is 2.7%. It's increasing with gestational age. Okay, and we can see from this table that since 2005 to 2014, during these 10 years, the total preeclampsia and eclampsia groups increased for 21%. That's a very large number. And also, like in FIGO reports, like each year, over 500,000 newborns died because of a maternal preeclampsia. And the death is maybe because of intrauterine fetal death, and it's maybe because of they have IUGR or maybe they have a placenta abruption. All these diseases can cause to a newborn death. Okay, so the relationship of what we mentioned before, the gestational hypertension, the preeclampsia, the HELP syndrome, and it can cause the IUGR, FGR, SGA, or intrauterine fetal death. All these diseases, they are combined together. They are all from one etiology. It's all placenta related. So the pathophysiology of the preeclampsia is very important because when we know the pathophysiology, then we know this is a placenta origin. And now we know if it's all placenta origin, and we know that if we control the placenta pathophysiology, then maybe we can control preeclampsia. So, but the major origin is still very unknown. We are still debating. It may be because of genetic factors. So if your family member, especially your mother or your sister, they have preeclampsia before, and then you maybe have the genetic traits. So also, if you are like obesity or you already have a chronic disease before, then you have more oxidative stress. And of course, maybe some immune factors that you have MK cells problem, then you can cause a placenta dysfunction. And after placenta dysfunction, then it can secrete a very harmful cytokines like SOPRO51 and placenta growth factor. This is a protective one, and other mediators. They can cause hypertension, proteinuria, growth restriction, and other complications. So the predicted model here, biomarker here is a SOFT1 and a PLGF. And as I mentioned before, all the cytokines reaction, it can cause the incomplete trophoblastic invasion. So because of this incomplete trophoblastic invasion, supposedly the anchoring villi, they will help our spiral arteries to grow better. So if it's a normal pregnancy, we can see here, the diameter of the spiral arteries is very wide and thick. So the blood flow can go through just very smoothly from the mother to the baby. But if for a preeclampsia patient, we can see the spiral arteries is very narrow and curly. So this is a very simple physiology. So we can know that because of the blood flow here is more smooth, but here is less smooth. So the patient might grow hypertension in the end. And because of the underdeveloping of the spiral arteries, it can cause the placenta size smaller, and so it will cause IUGR. And it's because of the in normal pregnancy, we need VEGF and placenta growth factor. These are the good cytokines. They can help the villi growth. They can help the spiral arteries grow better. But if we have a very harmful biomarker like SOFT1 and this SENG, it can cause endothelial dysfunction. So like it make the preeclampsia growth, the vessels become narrower. So like this is the normal diameter and the preeclampsia diameter is very narrow. Okay, and the preeclampsia can progress with gestation weeks. So as we can see, all the harmful cytokines, they can develop from gestational age weeks 10 to gestational weeks 40. So if a patient like is 30 weeks or 40 weeks, they may develop more, accumulate more damages in their body. So the gestational weeks growth can make a preeclampsia more preeclampsia growth happens. And because of the arteries and because of the endothelial dysfunction and because of the placenta not growing very well, uh, eventually they will develop those disease. So it can harm our hematology system, it can harm our CNS system, it can harm our cardiovascular system and our kidney and our liver. So we can see from the hematology system, you might have anemia, thrombocytopenia, and cardiovascular system, you might have a hypertension, coronary artery disease, heart failure, or other cardiovascular disease. And from the kidney, then you can have a decreased urine output, and eventually you will develop the proteinuria. And because of proteinuria, you will have more protein comes out from your body, so you become edema. Of course, in the end, we might have a renal failure. And for the liver, you might have a hepatic involvement, so you can have a hepatic failure or jaundice or elevated liver enzyme. As we told before, the HELP syndrome is majorly about the liver problems. And of course, this kind of patient may have a pancreatic involvement, so they have a more increased risk of pancreatitis. And for we talked before, the proteinuria, so you can cause a generalized edema, extremities, but more severe, if it goes to your lung, then you will have a lung edema, and you can have a hypoxia problem. And in the end, if all the disease they develop just to our brain, then we might have a cerebral edema. Then when you have cerebral edema, then you will have headache, visual disturbance, we call it scotoma, and maybe most important form, you can have a stroke or seizure. So you will have a consciousness change. So the severe complication of preeclampsia, as we can see in the picture, it can harm our CNS system, cardiovascular system, hematology system, renal system, liver system, and of course, our major client in our body, the baby. So it can harm our uterine placenta function. So it can cause uterine placenta dysfunction, including what I told before, the IUGR. And of course, you might have oligohydramnios. And in the umbilical artery, we can find out you have some abnormality. So maybe you will have absence and diastolic flow or reverse and diastolic flow. We call it ADR or ADV or RDV in your umbilical cord flow. So with now, I think everybody can understand that preeclampsia is a very severe disease that it can harm the pregnant woman from the toe to the head, and of course the baby. So the definition of a preeclampsia now we already understand it can because it can harm our vessels, so you will develop the hypertension after 20 weeks. So if you have a new onset of blood pressure more than 140 versus 90, systolic blood pressure 140, diagnostic blood pressure 90 after 20 weeks of gestation, and remember that you have to measure it 2 times differently in 4 hours apart because pregnancy woman is very easy to have a white coat hypertension. So either they have white coat hypertension or they have just like a positional hypertension or hypertension. So we have to make sure that we check this blood pressure twice in 4 hours apart. But if you have a patient that already have a hypertension more than 160 or more than diastolic blood pressure more than 110, then it's already a severe form. So in that case, you have to treat your hypertension immediately. But for this, we call it hypertension. And then if you have a proteinuria, the proteinuria measurement we'll talk about it later. Or you have an end organ dysfunction, then we can call it preeclampsia. The end organ dysfunction is just like what we mentioned before. If you have a CNS or cardiovascular or renal or hepatic function, then this is an end organ dysfunction. Okay, then this is a preeclampsia. Before, like 10 years ago, we have the preeclampsia definition as hypertension, and you must have proteinuria. If any one of you are aware known of the previous diagnostic criteria. Maybe 20 years ago, you need to have hypertension, you need to have a proteinuria, and you need to have edema. But now we only have to have hypertension and proteinuria. And now in 2025, our diagnostic criteria is hypertension with proteinuria, or you don't even have to have proteinuria. If you have hypertension and organ dysfunction, then we can call you as a preeclampsia. Of course, we can differentiate classify them into gestational age. So if you're a patient like come to your clinic or your hospital with term preeclampsia is already over 37 weeks, then you don't need to worry, just delivery. And there's no hesitation. But if it's like very mild, it's only a little bit elevated blood pressure and she doesn't have any other discomfort, then we can see when is the best timing for delivery. But if it's over 37 weeks, you don't need to hesitate too much. And for the more severe form is the early onset preeclampsia. So if you have a patient like this remote from term, say maybe 24 weeks gestation, then it's very difficult. We have to save a mother, but the baby is very immature. So what we want to solve and want to treat is the early onset preeclampsia. If we can prevent the early onset preeclampsia, then we can decrease many preterm babies. Okay, and the classification, the most important thing is that we have to classify them into the non-severe type and severe type. And for non-severe type, as we can see here, that is a blood pressure only 140 or diastolic pressure only 90, and they don't have all these end organ dysfunction. They might be just have a proteinuria or even not severe, then we call it not severe type proteinuria. But for severe type, you can either have proteinuria or not. But if you have any of these, you don't have to match everyone. You don't have to have thrombocytopenia, also liver function abnormality, also renal insufficiency. If you have a patient like meets all these abnormality, then it's a super severe. So just delivery, no matter gestational weeks. Okay, so we only have to meet one of these criteria. So if you have a systolic blood pressure over 160, it's already severe type. If you have a pulmonary edema, like you have a patient come to your clinic with a low, with a okay, like 140, 90 um, blood pressure, but she already have a dyspnea or she already have a visual disturbance, then she is already classified as severe type. Please do something. Okay, so the management flow chart today, we will see that we're already very familiar, what I told before, like the preeclampsia, the definition, and the etiology, why it becomes preeclampsia. It's all a placenta disease. And now we know the severe forms of the preeclampsia and how important it can cause to our mother and our baby. And now we have to understand how we do the management. So today we will, first, we have to identify which kind of groups are the high risk groups. So we have to offer those high risk groups the POKI, the aspirin to do the population. It's the most important thing today. And then we will do the blood pressure control. And also we have to know when we can do the earlier detection. It's a urine protein. And how do we identify the severe features we told before? If we identify the severe feature, then we have to decide the delivery timing. And also there's a new biomarker, like I told before, the SOFT1 versus placenta growth factor. It can help us to screening all those high risk groups. And when the patient already have a HELP syndrome or a severe feature, we have to prevent them go to the seizure attack. So we have to give them the magnesium sulfate for seizure prevention. And for postpartum care, if you already is a have preeclampsia patient or a severe form, then you have to have a 24 hours MGSO for even postpartum. After delivery, also continue the magnesium sulfate for 24 hours. But if maybe we can have a patient that have a postpartum new onset preeclampsia. We call it postpartum preeclampsia. So the short-term care and long-term care of all these preeclampsia groups. So now let's see what are the risk factors of preeclampsia. As I mentioned before, we have a lot of guidelines. We have the ACOG, we have a NICE guideline, we have SOGC, and we have WHO guidelines. All these guidelines that I mentioned almost the same thing, but different in slight ways, like the age. Some call 35 years old a high risk group, some call it a moderate group, but some identified 40 years old as a high risk group. So uh, which one will you choose? I think it depends on your personal personal ideas and it depends on your hospital's criteria. So if you're very like strict, very strict, you want to find out more risk factors. You want to have more groups patients that you have to put them into a monitoring. So maybe you can like 35 years old patient to become the moderate risk factor. But if you like a more loosen, you don't want to frighten your patients, then you can use a 40 years old as your moderate risk factors. Okay, but if we look into all the high risk groups, then we can find out a very similar thing is that if you have a patient, she had a previous pregnancy with preeclampsia. So we can see here from ACOG to NICE to SOGC, previous pregnancy with preeclampsia, previous pregnancy with preeclampsia, previous pregnancy with preeclampsia. All these patients, if she already have preeclampsia, on her previous delivery, then we can know for sure that this patient will develop preeclampsia in the end of her trimester. But which gestation weeks can we postpone is a major thing in this pregnancy. So for this kind of patient, remember to give them prophylactic aspirin. And for other things like she already have a chronic hypertension or she have SLE or she already have a diabetic problem or she have renal disease like nephrotic syndrome patients. And the interesting part is the multifocal pregnancy, like if you have twin pregnancy, some put it as a high risk factors, but some put it as a moderate risk factors. Okay, so this table is much better because it just classify everything here together. So for ISHP and ACOG and NICE guidelines, these are the three major guidelines we will look up to. So the high risk groups, we have something in common, like I told before, previous preeclampsia, chronic renal disease, chronic hypertension, diabetic mellitus, uh, lupus syndrome patients or APS syndrome patients. But here ISHB more strict, so we can see like the BMI over 30 is a high risk group. But here in ACOG and NICE guideline, they have a body BMI more than 35 is a high risk group, is a moderate risk group. So as I said before, uh, it's your own decision to find out the high risk groups. So if you want to be more strict, then we can use this one. But you don't want to be so strict because maybe you don't want to frighten your patients, and maybe you can use this one. So I don't have a personal preference. For me, I think I'll be more strict. So if my patient is over 40, I will give them preeclampsia population for aspirin. And for me, I will use a BMI over 30. So, and the other things depends on you. And something is more interesting if you have a patient that have a inter-pregnancy interval more than 10 years, like she had a baby in 20 years old, but then she had her baby at maybe 35 or 30 years old, then her body system, maybe she grow fatter or any other things, it could become different. So if the inter-pregnancy interval is more than 10 years, then the previous things might not be taken into consideration. Okay, but we also always have to remember the high risk factor is the previous preeclampsia. Okay, and because of the all these guidelines, NICE guideline, ACOG, and ICHP, and they also put the first delivery, like first pregnancy, into the moderate risk groups. So we have something that we are very curious if because every woman can come to a clinic as the first pregnancy. That's nothing to doubt, right? Every woman must have a first pregnancy, then they can have the second pregnancy. So the problem is that we don't know her history. So if the first pregnancy woman comes to a clinic and she's very young, she's only 20 or 30, and she doesn't have a family history, she doesn't have a chronic disease, how do we identify she as a high risk group? Will she develop a preeclampsia in the end? We don't know. So uh, aside from all these guidelines, we can also use the FMF system. The Fetal Medicine Foundation, I believe in your country, many people are also familiar with the FMF. The FMF, they will do the first trimester down screen. I think everyone knows that. And also now they have the first trimester preeclampsia screening. By using the mean arterial pressure, by measuring the uterine artery pulsatility index, and also by the biomarkers as PAPA and also PLGF, we can find out the risk of the first pregnancy women. So that's why I said before, if we measure the medical history and characteristics, and also the mean artery pressure and mean uterine artery pressure, or PI, and also PLGF, if we combine all this together, we can find out if we just use the maternal factors, we want to detect the early onset preeclampsia before 34 weeks, the detection rate is only 48. But if we combine with maternal factors with the mean artery pressure, its detection rate is better. And also, if we can combine the metal factor to the mean artery pressure and also the uterine artery PI and also the PLGF, then we can make the detection rate high up to 90%. It's a very big progress. So in my clinic in Taiwan, many people will do the first trimester screening. In my clinic, if my patients already have what I told before, the risk groups that are already high risk factors or they're moderate risk factors, I will just give them the aspirin. But if for the first pregnancy and she doesn't have any risk factors, I will persuade them to do this FMF screening. Then if the screening shows that they have a very high possibility of preeclampsia before 34 weeks, and then I will suggest them to just take aspirin for population. So the aspirin is because after this trial, the aspirin trial, we found out the aspirin can reduce the rate of preeclampsia. For preterm preeclampsia, we can decrease like 62%. And for early onset preeclampsia, we can decrease more than 82%. That is a very, very important progress in the treating preeclampsia, because when we already have all the severe features that we cannot do anything, we can just deliver a baby and stabilize the mother. But if we can use the aspirin from the early that we know before it's a placenta disease, so if we help the placenta to grow better by using aspirin, then uh, we can have less and less early onset preeclampsia. So that's the most important information today. Like we do the risk factor checkup by metal factor and by using the FMF method, then we find out the high risk group and then we get aspirin. By giving aspirin, we can, like from here, we can make the platelet activation, prevent them by the cross reaction. So for the high-risk patients, we use the 100 milligram aspirin from 20 weeks of gestation because from 12 weeks gestation to 16 weeks gestation is the major period of the placenta growth. So we suggest all these patients to take aspirin. It can decrease high risk preeclampsia. So, like we told before, we can identify the high risk group, we can identify the moderate risk groups, and if for those low risk groups, then we can send them to do the FMF preeclampsia screening. And for these patients, we give them aspirin. And for aspirin, as I told before, all the guidelines, they have different ideas. So it's also your own choice to think in your hospital or in your own practice, which kind of medication dosage do you want? But it's not much difference, like 81 or 75 to 150, and sometimes like the ISHP, because maybe most of the patients in USA are the BMI are higher, so they have a higher medical dosage. But for in our country, we just use the 100 milligram because we only have the 100 milligram dosage in our pharmacy. So we just use the 100 milligram. It's easier for the patient. They just have to take the aspirin once per day in the night. Okay, so like this, the daily dose and the timing of treatment suggested is from 12 weeks to delivery. I will use this from 12 weeks to delivery. And some will, before 20 weeks, they think it's okay. I think before 20 weeks, if you have a patient that identified as high risk group, you can still give them aspirin. It's better than nothing. It's better than nothing. But if your patient is already over 20 weeks of gestation, then the aspirin may not be so useful. So supposedly, we will still wish that every woman can come to a prenatal visit early on gestational weeks, and we can give them aspirin control from early gestational weeks. Okay, so aspirin is for prevention. That's the most important thing that we have to understand today. And for this, we will suggest them to use at bedtime. Because of the research, they found out that during bedtime is the best time for the medication do their job. So start both aspirin, or we call it bulky, before 16 weeks of gestation. Take it every day, and best timing is before bedtime until the 34 or 37 weeks, or it depends on you when the baby has to be delivered. Okay, and aside from the low dose aspirin, you can also suggest your patient to have more calcium intake. It's very important. It's now the only recommendation we will suggest: the aspirin, the calcium, the vitamin D, and also do the exercise. And for dietary advice, we, of course, the healthy way, the low salt, low calories, all those healthy food, we should suggest them. And for before, some people will talk about like fish oil or omega-3 or other things. Those are not evidently based effective. So only low dose aspirin, only calcium, and only vitamin D, and only excess suggestion for the prevention of preeclampsia. So we have to encourage our pregnant women to do the exercise, either aerobic or stretching or muscle resistance exercise. Just if they don't have a preterm labor signs, they can do the exercise during pregnancy. Okay, now we comes to the blood pressure control. So the target blood pressure control, before we think it's best to control our SBP from 130 to 140, and that's the blood pressure is 80 to 90. And of course, we have to know that if your SBP, systolic blood pressure, is greater than 160, you must control and you must immediately give them medication, or otherwise they may have stroke or other things. But if like a chronic control, then now we suggest we control our diastolic blood pressure. So because before, many people they only care about systolic blood pressure, they forgot how important the diastolic blood pressure is. So now we will suggest we have the tight control of the diastolic blood pressure. So if your patient, she has diastolic blood pressure less than 80, then maybe she doesn't need to have a medication. But if your patient like is above 85, As we know, 90 is hypertension, but it's above 85. You should start give them. You should just start to give them antihypertensive agents. And if your patient is 81 to 85, then there's targets the best your diastolic blood pressure we want. So if it's very high, more than 105, you must immediately go to the maternity unit and within 4 hours, and best to control the diastolic blood pressure. And if you're like normal, then it's okay. And if it's above 85, then you should have the antihypertensive agent. Okay, so for the medication we choose is labetalol, hydrolysine, and nifedipine. As all we know, in pregnancy women, we cannot have SEI or ARB. Like it's a common sense. If we give them SEI, ARB, they might cause fetal like some deformities, or they can harm their renal function. So it's in other ways, it's very easy in pregnancy. We only have this kind of medication, and we only have labetalol, we only have hydrolysine, and we only have nifedipine. And some hospital they may also have the mesodopa. So in the end, we have four medication: labetalol, nifedipine, hydrolysine, and mesodopa. And for among these four medications, we only use labetalol because it's the best one. The labetalol only if when your patient have asthma, then you have to change to nifedipine or hydrolysine. But if your patient they do not have any contraindication like asthma or other cardiac function disease, then we can just give them labetalol. It's a medication of choice. But if you use labetalol and you cannot control, then we can switch to nifedipine. It's much faster, and also the hydrology is the fastest control of blood pressure. But because of hydrology, it acts very fast, and it just diminishes also very fast. So it's not often used as a chronic control. So in my clinic, my patient will have labetalol according to their blood pressure. If they're very high, they maybe take one tab once and maybe twice per day. But if the blood pressure is not so high, then maybe can only have the half of the tape. So it depends on the patient's blood pressure range, and we can just adjust our dosage. But it's only the labetalol we use here. Okay, so the first line is labetalol, and if labetalol is not doing well, or the patient have asthma, then you cannot use it. Then you can switch to nifedipine. And nifedipine they have short form, and also they have a long term, uh, chronic resistant form. You can use each kind. Depends on which kind you use better, and depends on the patient how they compromise with the medication and the mesodopa. But we don't often use the mesodopa. Okay, so the BP control one is easy because we only have one medication is our first choice is the labetalol, and then is the nifedipine. Okay, then we will talk about what is urine protein and how can we do a earlier detection of a urine protein. So as we know, the definition of preeclampsia, we have hypertension, we have to have a proteinuria, or we have end organ dysfunction. But when we have end organ dysfunction, it's already the severe type. So what we want to do is that we find out a patient with proteinuria so that we can have an earlier diagnosis of mild preeclampsia. Okay, so this is the ACOG diagnostic criteria, the blood pressure here and proteinuria or the severe features. So in the proteinuria here, we can see we can use the 300 milligram as a diagnostic criteria for the 24 hours urine collection, or we can have the protein to creatinine ratio, or we can have the dipstick reading. So here, okay, okay, so can anyone erase the okay. So we know that from proteinuria, the spot urine dipstick and the spot urine protein to creatinine ratio, and also spot urine albumin to creatinine ratio, and the 12-hour urine protein and 24-hour urine protein are maybe the choices that you can use to do the proteinuria assessment. And this is very interesting. This is a heat coagulation test. We can see from this table, if from this tube, before you do the heat coagulation, and you can see the proteinuria words very clearly from the tube anterior, and we can see a background the words proteinuria, then it means it doesn't have a proteinuria is clear. But if like this, we cannot see the proteinuria words very clearly. It's very severe proteinuria. We call it a 4+4 proteinuria. So it's a it's a it's a procedure you can use if you do have a heat coagulation test. But it's just like I want to show everyone that if you have a very severe proteinuria, then your urine can become very turbid. How, okay, so uh, in clinic, we often have the spot urine dipstick. I think everyone is very familiar with this one. If we just use the urine dipstick, and we can just measure the like a 1+ or 4 2+ or 4 3+, 4+, we can know the how much is the urine dipstick. We use 1+, 2+, and it's easy, it's cheap, but it's inaccurate because we can only know it's 1+ or 2+, but we don't know how much is the proteinuria. So for the gold standard, we use a 24-hour urine protein, and this is a 300 milligram here. It's milligram and it's misspelled here. So 24-hour urine protein is a gold standard, but we know that we have collected a patient's urine protein for 24 hours. So either they have to do it at home or they have to be admitted to collect all the 24-hour urine. Imagine like if you go to the bathroom in the night when you are sleeping, you wake up, you want to go to the toilet, and you still have to collect your urine. So it's very troublesome. So not many people do this. Only if your patient is already admitted to your hospital and you can do a 24-hour urine protein. But imagine that we're in a clinic, so we don't have so much time for the patients, and we don't have so much time, so many efforts to do all these things. So I would suggest everyone to try to use this one. Is a spot urine protein to creatinine ratio. I think everyone should have heard of it. If you never heard of it, and maybe you can just ask in your hospital or your colleagues if they work in the nephrology department, like if they're a kidney doctor or they're like a metabolism, like the diabetic mellitus doctors, they are quite familiar with the protein creatinine ratio. It's a spot urine, but we will use the machine to detect the protein amounts in the urine, and also we will detect the creatinine amount in the urine. So by dividing the protein to creatinine, then we can have a ratio of the accurate amount of the protein amounts in the urine. So it's very accurate, but it's more costly than dipstick, but it's easier than the 24-hour urine protein. So it's the best choice for now. Okay, so also we can look up to all the evidence, all the guidelines, and all the papers. We can see because of the kidney damage, so the patient can develop a protein. And aside from protein, we can also use albumin. So like in these guidelines, they suggest we can use a protein to creatinine ratio, and also we can use the albumin to creatinine ratio to detect the urine protein to replace the 24-hour urine protein. Okay, so no matter if you look into the ACOG or NICE guideline or all the guidelines above, we can see in their tables, they have all these things inside. Just look clearly. They have a 24-hour urine protein, they have dipstick urine study, and they have a protein to creatinine ratio study. And in some guidelines, they will tell you you can use the albumin to creatinine ratio. So you can use this urine protein to creatinine ratio, or you can use albumin to creatinine ratio. They can both be used to detect um, early onset proteinuria. And the albumin to creatinine ratio is more sensitive, but it's more costly. So for here, the UPCR, we use it greater than 30 milligram per mmol, or you can use just a ratio like larger than 0.3, like here. Larger than 0.3 is if it's more than 0.3, then we can call it as a proteinuria. Okay, and for 24-hour or urine dipstick is not accurate. But if you don't have anything else, if you like in your clinic, if you don't have this UPCR measurement, then of course urine dipstick is the first and the most easy one that we can obtain. But if you have a patient, you already have a urine dipstick more than one plus, and you cannot define if it's a real urine protein or if it's just a misunderstanding, then you can send a patient to have a more accurate UPCR ratio detection. Okay, so now we know
Okay.
like so now we know that we can use your urine protein to for earlier detection. Now we have to come to the important part that we have to identify the severe features, and then we have to decide when we do a delivery, and we have to decide when we give them magnesium sulfate for seizure prevention, and all the important things here we are going to discuss about in this chapter. So here I want to suggest you to list novel biomarkers here. The SOFT1 versus PLGF is used here to predict the severe feature. As we said before, the SOFT1 is a harmful biomarker, and the PLGF is a protecting factor. So if the SOFT1 is higher, like here, is higher, then we can assume that the body is more toxic now. So if it's higher than uh, 110, then we can predict that women can develop a severe feature near 2 weeks. So in the New Zealand guideline, they use the list ratio to detect if you have patient that the ratio is less than 38, then we can like make the patient to let them just relax. They don't need to worry so much because their ratio is low. So the possibility of them to develop a severe feature is not possible. Oh, thank you. Thank you for the erasement. And now if you have a patient, the ratio is more than 38, then we can know they maybe have developed a severe feature in 2 weeks. And it's very high, like more than 110 is always a red light. So it's a red light and you have to let the patient come back to your clinic more often. Okay, so we just remember here, if it's below 38, it's okay, but it's above 85, then it's a high risk group. So we have to do the checkup more often. So the proposed screening method and management method during pregnancy is from the beginning, the 11 to 13 weeks, we do the first trimester screening as we told before. For high risk groups, we give them aspirin for prevention. And for the low risk group, they don't need to, and they just keep the weekly like a antenatal care before 20 weeks, you have once every month, and after 28 weeks, you have twice every month. So 2 weeks per you come back to your clinic every 2 weeks. And after 37 weeks, you come back to your clinic every weeks. So during all these prenatal tests, we will do the blood pressure and we will use a dipstick to test the urine protein. But if you're not sure, then you use the urine protein creatinine ratio to identify if they really have a protein urea or not. And then when it goes to the second trimester, we can use the soft one to do the survey to see if they have a high risk of a severe feature of preeclampsia. And so that is during the whole trimesters, we can use the first trimester screening and also the SOFT1 marker and PO drift marker as a second or third trimester screening. Okay, so we come back here to see our severe feature. So as we mentioned before, the systolic blood pressure more than 160, and diastolic blood pressure for over 110. And also, if you have a thrombocytopenia, if you have impaired liver function, or if you have a renal disease, or you have pulmonary edema, or you have a new onset headache and it's not effective to any medication, and if you have a visual disturbance, then you are already have a severe features.